Why don't we? I think we got a pretty good full group right now, so I think we're going to go ahead and get ourselves started. Welcome to June, everyone. This is our our last call before it's summer, officially summer. So we're going to do our typical, just kind of brief intros, do a little housekeeping. And then shift most of our time to Melissa Maxey, who's going to tell us more about kind of ACT clients and high-risk behaviors and our role in supporting them through their recovery journey within ACT teams. And then we said right before this, we really need to honor our opportunity to kind of share with each other and have open mic time. So we are going to try to have a hard stop here at 4 o'clock Eastern so that you guys can ask questions of each other. And, sometimes we use this as an opportunity to just query the group on our own questions. Many times you all are wanting to kind of compare notes with one another about different approaches within your team. We know there's a lot of stuff going on around funding right now, so those might be some of the topics that we talk about then. And then just to highlight our next meeting, then we don't meet every month, but every other month is on Monday, August 4th at the same time, same place. Just a quick just reminder to folks that we have moved, and this is a temporary moving for those of you who were used to, and it's now been almost a year, but the MHTTC website is kind of where you got everything before. Right now, we're just hosting everything on the Spirit Center's website from the MHTTC webinars. You would go over to this National ACT consultation calls. Again, Lorna and I are committed to try to figure out getting a joint website between University of Washington and University of North Carolina so that we can house everything together and take the best of what both of our groups have to offer, but we're not there yet. It just doesn't apparently materialize on its own. So, surprise, surprise. And so if you click on there, then you'll see National ACT consultation calls, and you'll see right below there's an assertive community treatment folder and all of our previous ACT psychiatric care providers series webinars, as well as the ACT team leader series, and then our National ACT consultation call presentations are in there too. Also, our ACT e-primer free course is also it's moved. So you want to go to the Healthy Knowledge website. You see the link right there, www.healthyknowledge.org. And you'll want to make sure to type in assertive community treatment, the whole word, not just ACT, because you won't be able to find that course. And just a quick note about housekeeping. Again, everyone will be muted with video off. We're recording this session. And I will put the slides in the chat, which you will also be able to access from our website afterwards today. Just a note that if you have any technical difficulties or just want to, make a comment about something, you can use the chat. So you'll just click on that and put that in there. But if you want to ask a question and you want an answer to your question, it's best for you to go ahead and go to the Q&A box. That way we can track who's asked questions, what the answers were, and that kind of thing. They get lost sometimes in the chat, especially if multiple people have commented in there. So we want to make sure we're just kind of getting everybody's questions answered. Also, when we get to the Q or the what are we calling it? Open mic portion of today. You can raise your hand and unmute, and then that way we can also have you kind of be a part of today's session and ask questions that way. So lots of different ways to get involved. And again, we're hoping to honor the whole open mic time in that 30 minutes at the end of our time today together. So with that, a quick introduction. So I'm Maria Monroe Davida. I'm with the University of Washington Spirit Center and oversee the training and implementation support of 22 what we call PAC teams in Washington State, but have also been involved in training ACT teams all over the country and recognizing many of you who I've worked with over the years. I also do research in this area and am the co-author for the tool for measurement of ACT or TMACT. And I'll shift it over to Lorna where she can say the almost exact same thing.
Yeah. So all that except for North Carolina and more the Southeast coast. And I think ditto with what Maria just said. Something that's always rewarding is coming here and seeing all the friendly faces by way of chat that's showing up to these meetings. So this is kind of a cool community because we do work that a lot of people can't really identify with. And I think you're with your people. And I think there's something special about that. So we are very excited to have Melissa join us today. You all, we listen to you when you tell us things that you want more training in or want to have as a special topic. Sometimes we don't have the easiest time of finding the person who can come and make the time to come and cover that topic with us. But thankfully, we've reached out to our friends. Yeah, it's you. Guess what, Melissa? At Case Western Evidence-Based Practice Center. And Melissa had the time and the willingness to come and meet with us today. So Melissa is a consultant and trainer with our EBP center there and has a wealth of experience of doing direct care work with folks with co-occurring disorder and mental health and substance use, both inpatient, outpatient, direct care, supervisor, team lead, ran the gamut, has decades of experience around doing education, curriculum development, and supporting folks with providing best care. So we are in good hands. And we know this is a topic that sometimes can raise some feelings and emotions because this is a challenging population. So we'll be in the background trying to help field questions that you have that we can directly answer and sometimes be punting them up for Melissa to help answer them too. So with that, go ahead. I'm going to go off screen and be lurking in the background.
Right. Are my slides up?
They look good.
They are.
Good. So I am so excited to be here. That introduction that Lorna gave is lovely, but I also wanted to mention one of the things that I did just before I came to the Center for Evidence-Based Practice was I was actually a team lead on an ACT team, and it was a culmination of a lot of years of doing co-occurring treatment. And so when I get a chance to come and talk to people about the ways that we address or handle high-risk behavior for co-occurring clients, I just get really jazzed about it. And the reason is because I know it's difficult. And I'm the kind of person that really enjoys working with people that I feel are underrepresented for their voice and sometimes have behaviors that are pretty complex. And so it is really my honor to be here today, and I hope you really like the information that I have. And I'm looking forward to some questions around it because I know we have a limited amount of time. I love whoever sent me the hearts, by the way. So I am so glad to be around my people because I feel that you're right. We're not always understood, and people are like, "Why do you do this?" Because it's awesome. That's why. All right. So today we're going to talk about clients and high-risk behaviors and our role and kind of get grounded back in some things that are helpful. This may be a review for some people, but what I would challenge you to do today is really think about where you're at in your space as an ACT team member and how you've been feeling about the work and some of the challenges. And as I go through the material, I want you to think about yourself and the team and how you've been functioning, not to be critical, but just to be like, hey, are we doing some of the things that would be most helpful for us as a team, actually, and also for our clients? Because this is high risk behavior clients really can get us to a place where we feel like we're not making an impact. That's why I think it's also so important to talk about this and actually put it out there. When I do trainings, I'm a supported person, and you can say or do anything you want. It's a safe space. So I'm going to really talk about the challenges today that I experienced and hope that you can get something from that as we go through the slides. And I'm going to talk a little bit today about best practices and what seems to be helpful. And many of you may be doing that. So I'd be excited to hear about that as well. So today I think it's really important for us to continue to ground ourselves as a team and as individuals in what is our role versus the responsibility of providing services to clients who engage in high-risk behaviors. It's this constant balance of really, we're going to look at, the challenges around that, but also what is our role in that? Because we can get very involved in what is happening with clients and very worried, and for good reason. We want them to feel better and we want them to be able to do the things they're telling us that they would like to do. And as part of my discussion today, we are going to be talking about readiness in the context of using a framework. And this is a suggested framework that has worked here in the teams I consult with. So it's stages of change. And we're going to spend specific attention on our short time here with people that are in earlier stages of readiness, pre-contemplation and contemplation stage, because what happens is those are our usually high-risk clients. And that is not to say that we don't have clients engage in behaviors on the team in different stages of change, but these two particular stages I think are important because it's the time when clients aren't even sure if they want to engage with us and may just be thinking about change as opposed to doing anything. And I'm so excited because now whoever does our lawn is out doing it. So give me a moment and I want to close the window so it doesn't interfere. Working from home in Ohio. It's so fun. And then I'm going to talk about some interventions that really kind of focus on what we would hope to do for clients with their health and safety as they engage in high risk behaviors. Because the reality is, some of our clients, due to issues that are very complex, may not be ready to do anything about what's going on. So we need to figure out how to best join with them, which sometimes it can be challenging. So, of course. In general, I like to start out with the idea that all of us are on the same page with regard to ACT services. We're trying to use a recovery-oriented treatment model so that we can do the best for our clients. When ACT was first developed, it was kind of the idea of you stay once ACT, you're always on ACT. But really, we've understood that people do get better, and we know they get better because we're seeing the work that we're doing on our teams. And so the reason I'd like to start with this is to help ground us in the fact that we are helping people try to achieve their best life. And I don't mean recovery in the idea of abstinence only type of work. I mean that it's person-centered. We're focusing on what people do well. We're looking at what brought them to this situation and how they're coping and how resilient they are. And we're using evidence-based practices, which I'm going to talk about today a little bit. And this whole process is we're starting to actually work with clients in a very intense way. So we get to see as they go through acute situations or crises, how that affects their functioning, and getting to talk to them and understand how things are going on with them and what their challenges are, so that hopefully over time, we actually can help them develop a plan that looks good for them and empower them to talk about what recovery looks like for them. The hope for us is that they have some improved health outcomes, they're feeling better, and their quality of life as they define it is better for them. And so that's the constant theme that's going to underline what we talk about today, and just trying to do things that help people get to that place of more stability in their lives. And the definition of recovery is returning to a normal state of health, mind, or strength. And the other one is I like the best in this definition is the action or process of regaining possession or control of something stolen or lost. And when I think about the clients that come to our teams, I think about all the loss and grief they have and the challenges they're having. And so any place that we can begin to help them look at what their life wants to be, what they can imagine their life to be, and maybe things that they want to recover and do again is the essence of our work. It's helping people figure out how to have a life that is going to be workable for them, and that they are going to have some of the things that they hope that they had, or they may have lost. So we did want to do a definition of co-occurring disorder. It's not as if some of us on this call don't know what it is, but I did want to talk about it a little bit. And the reason I picked this topic in general is because co-occurring disorders tend to be overrepresented on ACT teams. So we have more clients that have co-occurring disorder. And by definition, someone has to have at least one substance use diagnosis as well as one mental health diagnosis. And honestly, for our clients, they tend to be in the more severe end of the spectrum for both. So it's important for us to think about how that affects our interactions with them and what challenges they're actually going to have as well. Then what I think makes the clients who have co-occurring disorder complex is the symptoms for mental health and the symptoms for substance use, either addiction or withdrawal, can mimic, um, interact, exacerbate with each other. And so sometimes, as you're talking about this case, even or dealing with someone in real time, it can be really tough to figure out what's going on and how best to interact, get things done as a case manager. And kind of learn what's going on with the client. And so, just in general, SAMHSA from 2020 talks about individuals diagnosed with substance use disorder are 50% more likely to be diagnosed with a co-occurring mental health disorder and vice versa. So, the other piece of this that's just a side note before we start in the material is one of the other self-reflections that I hope you do is thinking about how, as a team member, how comfortable you feel with dealing with both disorders. And so, are you getting enough training and supervision around co-occurring disorders so that when things come up, you feel good about being able to handle it and have a plan? Because not everybody's trained in co-occurring. They may feel more comfortable intervening with mental health issues or substance use issues. And so it's really up to us to think about, okay, how can I make sure I'm the best at doing this work because it's so complex? And this type of work isn't just for the therapists on the team, it's for all of us to kind of know what's going on with the client. Now, we may not do therapeutic interventions per se like a counselor, but we have to know some of what's going on with the client from a symptom presentation to be able to interact with them for their own safety, ours, and also to get some of their goals done that they've set for themselves. So I have 5 model principles when we talk about when we're thinking about dual diagnosis or co-occurring care. And so we are going to touch on actually most of these today. But one of the things you want to think about when you're doing co-occurring, when you're working with clients with co-occurring, you want to have some model for readiness that matches treatment interventions for the client's readiness, so stage-wise treatment model. You want to have something that follows behavioral principles, and what that means for us, and we'll talk about it a little bit today, helping clients begin to unravel, hey, how am I thinking and feeling about this, and how does this affect my behavior? And what kind of coping skills do I need to think about as I go through and start to figure out what's important to me and what I'd like to work on as I work with the ACT team? And the other thing that is very helpful for clients who come to ACT teams is this expectation that it's not abstinence only, that we do need to offer clients the support in wherever they're at with their change around substance use, around their mental health. And so harm reduction is going to come into play, and we're going to talk about that today quite a bit. And then one of the things we do know is non-confrontational approaches for people that are at the more severe end of the spectrum. Motivational approaches are a little bit more helpful in helping the client feeling cared for, understood, engaged with, which is important to this process. And then underlying all this is really considering the interaction between mental health and substance related issues and really bringing that to the forefront on teams and talking about it regularly. So we begin to make sense of what is going on with this particular client. because in any situation with a client with co-occurring disorders on our teams, and you all know this, the person could have a diagnosis of schizophrenia and have a substance use disorder. They're using methamphetamines. And then I could have another person with the exact same diagnosis, and they're going to present very differently to the team based on how they're doing. And so we always kind of keep in our minds, how is all this interacting? So that we can best treat and educate the client that we're working with and help them get to their goals. So in a lot of our work, and I hear this all the time because I travel around the country as well. I'm in Ohio, in my house right now doing this training. But I do travel around, and one of the things that people talk about a lot that's important on ACT teams and is absolutely valid is this idea of meeting people where they are at. And one of the things I think about when I think about clients with co-occurring disorder, this has an inherent challenge with it because many of the people that start on ACT teams in general, but also with co-occurring disorder, may be in a place where they are struggling with symptoms of their mental health. They're struggling with symptoms from their substance use disorder. And we are then tasked with interacting, taking them in our cars, getting practical things done with them. And so it can be really challenging, and a lot of feelings can come up for team members. It can be overwhelming at times. And sometimes it feels like, gosh, I can't even make an impact with this person, or even in earlier stages of change, really bond with them. And so sometimes it can feel pretty anxiety producing when we are doing our best at just trying to be there for people. And what's really important about this training is the other piece of it for me is being honest with your team members about challenges you might be having, because these are complex issues, and being able to support people is our job, but it can get in the way if we feel like we're overwhelmed or don't really understand what's going on with a client. And that can happen pretty regularly. I don't know about any of you on here, but I've had an experience where I'm working with a client and they have complex issues, co-occurring disorders, some medical issues, and there's a whole team sitting around talking about it and trying to figure out how we can best serve this person. And sometimes there's not clear-cut answers. And so being able to be honest about, gosh, this is a concern for me as a team member, really helps kind of get us in the mode of supporting people where they're at, even if it's like hard for us. And so some of the ways we can do that, and I didn't attach it, but I'm going to attach it to the group. I'll send it to Maria and Lorna for you to have. But the Center for Evidence-Based Practice has a stage-based decision guide for ACT or integrated dual disorder teams. And some of the things that I think are important to think about in the early stages of clients coming to us are the questions that we have at the top. And this guide is complete for all the stages of change, but I wanted to talk about this one because that's what we're focused on today. And what I want you to think about is, I'm not going to read the slide, and I'm going to provide you with the guide after this, but the basic things we want to know when we are working with people that are unsure of what they want to work on, if they want to focus on substance use disorder or working on their mental health, the things we need to do as a team, as team members, is figure out, do we know what matters to this person, what values they have or goals? So before we even identify if they want to work on certain issues, we need to get to know them as a person. And this gives you some strategies to do interventions with after each bullet point. So if we don't know what matters to the person, are we then having conversations? And if we are, what's getting in the way of what matters to you, and what help you get what matters to you? So are the clients in a place where we know what's going on, or are there barriers to them being able to get their needs met? And there's some common traps that we can fall into that I'm not going to go over today, but it gives you the learning about, am I doing the things that would best serve having a conversation with this person? Is this person even willing to talk with us about their issues? And are they willing to develop a crisis plan? Are we listening carefully, even when they are in crisis, about what's going on with them? And do the team and the individuals agree on direction? Do we know what we're doing with this client? Are we all on the same page? And can a discussion of change occur for this client? So some clients, they're not ready for that. That's what we're going to talk about today. Some clients would be ready for that, and there's some guidance around that. Um, the column at the end, which says continue. So in early motivation, what you're going to be focusing on as interventions primarily, even if we haven't answered all these questions, is outreach, basic need assistance, assessment every time you're meeting with them. How are they doing? Non-judgmental interactions, giving a sense of hope and optimism that they can do this, they can do the things that they need to do for themselves, approach them with compassion and concern. If they become resistant, understand that this is a process that we actually, I'm going to talk about a little bit, that we can contribute to or actually affect in a way that's positive. Use ORs, which is open-ended questions, affirmations, reflections, and summaries to get to the meat of what's going on for that client, and then be trauma sensitive in our services and avoid real directive interventions. So directive means I'm reminding, telling, warning the folks that I'm working with of their consequences. And so we want to really pare that back so we don't increase their resistance. So a little bit about something we talk pretty regularly about at the centers is this idea that treatment works. So whatever we've decided to do, from staging someone so we know what interventions to use that will be appropriate to their readiness, to using motivational strategies, to using CBT, DBT, whatever the treatment modalities we're offering, the only way we're going to get that to a client is if they want to stay and feel like they're going to come back and open the door for us and, enjoy being with us at some point. We have to build rapport, respect, and a relationship with them, or we can't even deliver services. Stage-wise treatment and motivational implications should become a natural consideration to help with this. So that's why I'm going to be talking about stage-wise today and some motivational interviewing perspective, and then talk about harm reduction. We don't want to see people leave treatment because then they have a whole host of high-risk behaviors that can lead them to not be around. We'd rather have them come and engage with us and have a relationship with us so we have a true understanding of what their challenges are. And that gives us food to be able to support them in a number of different ways, even if they don't want to talk about it. I like this graphic. This graphic reminds me of my life. I have all these plans that are happening that I think are going to go a certain way. And then what really happens is what's down in the bottom. And I think this is important, and I want to give this perspective to the ACT teams because the reality is when we meet a new client, there are things that we need to get done from a compliance perspective, from a treatment planning perspective. And so a lot of us that come to teams are doers. So we're already in action stage thinking about, okay, what are the things we need to do? And I understand that you may have sat and talked with the client. I'm not saying that you're trying to take over their treatment, but we are in charge of doing an assessment, planning for goals on the treatment plan, and we're including the client in that. But in our heads, we may be thinking, okay, this would work. These are the things that they work on. They need to work on because we're asked to do that, right? We're asked to get that organized so there's priorities and goals, and we can explain them and get funded. So we're in that mode. And what we need to be careful of if we're going to be effective, it's good to be a doer and a goer on a team. It's good to think ahead as a staff person when you're working with clients. What we need to remember so it doesn't feed our frustration is the reality is change happens, there's fits and starts. Sometimes it's easygoing, sometimes there's storms, sometimes there's relapse, sometimes there's major things that happen. That's normally more the reality. So we, even in our planning stage, we're not doing anything wrong by doing and thinking, oh gosh, these would be good things for this client to work on. But we have to be careful that we sit in their reality and not get frustrated with them. I do know team members that do get frustrated. Sometimes they feel like clients are pretty stuck and they're not moving forward. And so that can affect the way we interact with people. If we have expectations that they're going to work a plan that really in reality is something that's a little bit different for what they want. So really checking our who we are as a person and how much we kind of feel like we want to get done with a person is important for us to not burn out as well. Because clients have all kinds of challenges and we need to be there to support them, and understand the plan for them is probably quite different than what we've kind of thought about in our heads. The other thing I wanted to say is it is really important for us to think about how we feel about mental health, substance use disorders, people having their own autonomy to change. Because if we don't examine those types of things, it can influence the change process in both positive and negative ways. So if we're feeling burnt out and we're feeling like the client is kind of stuck and we're not sure what to do with them, that can affect our ability to see what is going on with the client, hear what's going on with them, and then also be present for when things happen that could be change oriented. We might miss it completely if we're really feeling very stuck with a client. And so we need to be careful about the context that we bring to our relationships with the clients, because we want to help them change and we can get in our own way that way. Does that ring true for anybody? I know there's a bunch of us online. And so we're not going to answer like out loud, but I hope that rings true for people. Yeah, okay, I'm seeing thumbs up, right? You know, we've got our own stuff going on in our lives, right? And so we really have to bring it for the clients. And sometimes that's difficult, especially for the clients they're with us and we're with them and they're struggling, right? It is not easy to sit with someone who is in pain and trying to figure it out. It's really a task. So remembering how we behave and communicate and how we think and feel and what we believe and perceive has an impact on our clients. And so one of the ways that I think about kind of keeping this in check is our own self-work, so that we're prepared to be with people and engage with them effectively, but it's also as a team, being able to kind of call each other out if someone's feeling burnt out or talking negatively about a client, or really actually just needing to tap out. Some clients with complex issues, if I've been working with them all week, I might not be super effective if I'm already worn down with how much time I've spent with them. I'm not a bad person. It's just a lot. And so being able to talk to each other as a team is so important, be able to have each other's backs, to kind of take over for someone else if we're not feeling it that day, because we really do have a lot on our plate when we're working with clients who have co-occurring disorder and doing high-risk behaviors. We're kind of running around our whole community after them sometimes. I did want to talk a little bit about components of change and how people change. So, because I think it's important when we put it and we're planning for what it's going to look like for people with regard to their change process. And there are three components to change that we talk about when we talk about motivational work or helping people uncover their own changes they'd like to make. And purposefully, we've made them red, yellow, and green. We use this slide quite a bit to talk about what happens in anybody's change process. So I want to talk about the first one is resistance. And what we see is a graphic of someone, pulling a goat and the goat digging in their little feet and not moving. And so what's important about this with regard to change is resistance does exist within someone's change process. It does require two people to have that dynamic. And it is a warning sign for us as we're interacting with people. If we begin to feel this, like we're kind of pulling someone forward or it's not feeling good, that's a sign for us that we need to stop, take a break, and do something different. Whether it's a topic that seemed to get the client not feeling it, whether it's our approach and our attitude that day. The point is, when we are experiencing that, and all of us might have had a client that gets in the car and the client's not feeling it. You got a lot of stuff to do, and they might already not be feeling like hanging out with you and doing things. That's a sign to look at our approach, or we could be talking about a topic that seemed to be something the client was interested in, and then all of a sudden it doesn't go well. When you're noticing that feeling, that's when you need to take a step back, because resistance is predictive of not change. When someone is in a power struggle with us and we're in that power struggle and we're not taking a step back, the chances the person's going to focus on change at that point are not as high. And we want to help them figure out what they want to do with their lives. And so being able to really realize when that happens and kind of switch gears and listen more and change our tactic is really important. Everybody, when they go through a change process, has an aspect of ambivalence, which is maybe even knowing, feeling like they want to go forward and do that change, and then sometimes not really wanting to do it, not being sure. It is a normal process. And what we have a chance to do is, if we realize it's happening and people are talking about it, we can then be cautious and attend to what they're saying that has to do with change. And help them talk about that a little bit more using open-ended questions and affirmations and reflections to get to the meat of what is going on with this change. Because if someone's going to change, they actually have to feel that the change is worth more to them than staying the same and being in the same situation that they've been in. And we want to help that process along by active listening and helping them talk about that change. Motivation, everybody has motivation. Sometimes it needs to be uncovered. We need to listen to what the clients are saying that are important to them so that we can help them uncover what is important to them and what's going to actually help them affect change in their lives the way that they were planning. And so when we hear people talking about change, when they are looking and doing actions that are leading us to believe something's different, we want to hop on that, make sure staff's paying attention to it, and really support that person in figuring it all out. And everybody is motivated. They have motivation. It's just what is going on with them and what is the factor to motivate them to get that change going. I said before that we are tasked to identify what the issues or problems are with our clients and to document them. What kind of things are they struggling with? In the midst of this, though, to be effective, we may perceive these problems or issues that need to be attended to, but these are the issues that they perceive as solutions to what has been painful for them or difficult. And so one of the things we need to be super careful about is not jumping the gun and talking about how they need to change things in a more directive way until we've gotten to know them and actually help with coping strategies. And they have to be open to that. One of the things that we get in trouble with as we think and plan, and everybody's felt this way. I know I have been, and I've been in the field, 32 years, I think. And I felt this way. If we can actually take people for who they are and pay attention when we feel like we have our desire to fix them or be responsible for solutions, if we can attend to that and not fall into that trap, we have a better chance of really helping people effectively move through what they would like to do and progress. oftentimes, and I know some of you will probably heart this, we have clients and we're so worried about them because they're engaging in high risk behavior and it worries us sick, right? You'd have to have no empathy to work on a team and not ever have felt that. And I'm not being judgmental. I'm just saying sometimes, the close contact with our clients, getting to know them and seeing their struggles, it can really affect us in a way that we feel like, oh my gosh, we got to get this stuff done for them because we want them to have a better life. It's not like we want to control their whole life. It's really because we want to help them. But what it actually does for the client is when we get more directive, it gives them a message underpinning this that, they don't know what they're doing or they're not the expert about their own life. And the other thing it does for us is we get in this place where we get worn out, fatigued, burnt out because we're trying to help them fix everything. And if you go back to what I talked about with actual journeys, there are going to be fits and starts. There's going to be all kinds of things that happen. And if we actually aren't aware of the fact that we're in that mode of fixing or being responsible, we can get in a lot of trouble and get really burnt out because we're so hooked to the outcome. This person has to show that they're better. And it's not a bad thing that we're wanting. It's just a thing that many of us have gone through. Motivational interviewing is one of the ways that can help us not feel burnt out when we're actually practicing those strategies. That could be, 6 trainings that I could do for all of you. So today we're not doing that, but I do talk about it a little bit. This slide particularly is a talk about not falling into common traps of trying to present a solution before we really get to know the person and what they would like to do. This is a graphic of what I've just talked about. And so we are in a role, whoever we are on the team, to provide services to the best of our ability, the interventions within our scope of practice, whether we're a peer, whether we're a case manager on the team, whether we're the therapist. On an ACT team, though, that's fluid and it's shared. We're sharing the service and the discussion with the client. Versus feeling responsible for them or taking ownership, the burden, or terminal authority, like we have this responsibility to make sure a client doesn't use, make sure a client doesn't overdose, make sure a client has housing. Now, what I will say about all this is, of course, we're going to be talking about strategies to address some of the things I just listed. But ultimately, the client is responsible for their choices and the outcome of their life. I know it doesn't feel like that, but one of our rules is to get that clear in our heads and also support each other if we get in too deep. Because ultimately, we don't have that ability to make someone fixed or better. It really is this client working with us and being able to tell us what they need and us doing our best job to provide that service. That's what our role is. It is not the outcome. And if as a team or as individuals, we get focused on, well, I'm only doing a good job as a team or as a provider if this person's getting better. We are then in that mindset of, oh my gosh, I need to fix this, and not really staying in lockstep with the client who has things that are happening for them that they need to figure out. That's our job, help them figure out, gosh, I had a consequence about this. What do I want to do about it? And help them unpack that baggage, not fix it. Now, I do understand there's times we get housing for folks, we help them with basic needs. But if you're an ACT team member, I remember this, we're going to Social Security to get someone's get someone's Social Security card, and the client's having a rough day. They're not going to be able to sit. They're not going to be able to ask for it. They have to go live. They've forgotten their password. All of that is still their responsibility. Our role is to hang out with them, figure out how they would like to handle it, offer solutions. And so being able to talk about that as our role is really important so we all don't burn out, because that gets muddled at times. And reminding each other and ourselves is the best thing we can do for ourselves and also the clients. We want to empower them to figure things out. We can't do everything for them. Um, and if we do, the outcomes are still theirs. This is a picture we use often at the Center for Evidence-Based Practice, and I want everybody to remember words matter. And so when we're in team, when we're describing clients, um, our perceptions and how we talk about clients, those are about connections. And if we use words, thanks for the heart. If we use words that label someone, which is a common trap in motivational interviewing, when we engage in labeling or shorthand to describe something that's going on with a client that really is much more complex, we can affect our connection with someone. And we can take a step back and not be able to provide that good connection if we are describing them in a way that labels them and we're taking it away from the person that they are. If I told you, I just gave you a quick report, hey, be careful with this client, they just got out of the hospital, they're known to be aggressive, and I don't provide any more information about that, that would be worrisome to someone. Am I going to put them in a car? What do I have to deal with? What are the things that are going on for that person? So I'm not saying that you can't talk about someone presenting as guarded. What I want you to think about is make sure it's not shorthand for a discussion that's more robust about what's going on, to um, why that person has that, like what has happened to them, how are they coping. These are things that people do as ways to cope, and that's what we're trying to help them with, kind of figure that out and unpack it. And if we don't explain further, I know team meetings need to go fast and we have a lot of clients, but if we don't explain further, we can get in that trap of just looking at them as an aggressive person. So that every time we're interacting with them, there may be a part of us that holds back because we're worried about that and we're not sure about how that works for them. Um, and all of us have heard some of these statements in in our work, and we just want to be careful that we just don't label someone as angry all the time, because it's going to affect our interactions with them. Having feelings of anger is normal if you're feeling like someone's crossed a boundary. So us figuring that out is important. Um, and being careful and kind of holding each other accountable as well. People are going to hang out with us and come back to us. So at clients, sometimes their engagement isn't consistent. Sometimes at the beginning it's really hard and then they stay really engaged with us. Sometimes they taper off at the end. There's all different ways that we engage with our at clients at all different levels. But what we know is people are going to come back to places they feel safe, useful, helpful, and hopeful, that they're getting the things they need and they're understood. And so when we go back to where I started with the recovery model, that's what we're trying to do, get people to hang out with us and honor us with their information, with their hopes, their dreams, so that we can maybe have a discussion with them about what might work, what options there are for them, provide education, all the things that we need to do. And so engaging with them is important. And so even if they leave the team, sometimes I've had the experience where they'll be like, oh, it was a bad idea, Miss Melissa, for me to leave the team. Can I come back? And really that relationship was what got someone coming back. When we talk about interventions that are helpful, and I'm going to focus on one or two today because I can't do all of them. But one of the things that is extremely helpful is having a way to talk about where people are in their thinking about any change they're making. Today we're talking about co-occurring issues, but having a framework that we can talk about and also that we can refer to drive interventions. What we know is nobody's motivation as they change is constant. If you think about your own change process, if you've done some big change, you're not always motivated. Sometimes things get in the way, life happens, and so part of what we want to do is actually try to understand what stage the person is in so we can match the interventions to help them with that. To pay attention to if motivation is wonky and how we can help them kind of figure that out. People also can return to earlier stages of change. They can go back to old behavior. That's pretty common. Returning to old behavior is normal. In some circles, they call it relapse. In stage of change, we kind of talk about it as old behaviors or returning to things that they were doing before. This is a graphic representation of the stages of change, and I'm going to go over it in the next couple of slides. But they include pre-contemplation, contemplation, preparation, action, maintenance, and relapses kind of on the side, and termination if people are leaving us and going to a different level of care. This is the framework from Prochaska and DiClemente that we use to talk about where people are with their readiness. Under the bullet points is what we would be doing, but I want to go to the next slide where it talks about the characteristics. On the staging tool we have, which I'll provide to you, it goes in a little bit deeper of what to look for. So when you're actually having a client if you're having a team meeting, clinical team meeting to stage people, that you actually use the tool and can talk about it a little bit in more detail and kind of get the stage set. But in pre-contemplation stage, the person that we're working with doesn't see a need for change. And the things that we're going to be doing are building that relationship and then exploring the person's own goals. And I want to talk about this here. The recovery-oriented slide talks about moving from acute care situations to a recovery, maintaining recovery. And what we're trying to do is help people figure out what their goals are through our relationship with them. And so it doesn't mean we don't talk about things that are going on with them. And in actuality, in pre-contemplation stage, it's really important for team members to be present as the person goes into crisis, because we want to be able to explore that, what happens after the fact. We want to be there to support. So the client sees us as an ally to figure out, hey, do I like what's going on with me? In any aspect, do I like what's happening, and do I want to do something different? And so it doesn't mean when someone doesn't see the need for change that we can't be there and be present for them and help them begin to think about, hey, is this working for me the way my life is? And that is through that relationship we're going to build. In contemplation stages, the person is starting to talk about their behaviors and considering the possibility for change. And that's the time we get to kind of build discrepancy with what's going on with people, and are they liking it? What do they think about it? And what are the pros and cons if they change? I just did a warning about needing to wrap it up. So I'm not going to go through the rest of them because we're focused on pre-contemplation and contemplation today. Different services are helpful at different stages of treatment. And so you see, these are the ones that I talked about before, but in contemplation stage, we also want to be working with family, building awareness or concerns of the problem, and motivational work, and also getting peers involved. That's important. Clients that come to us are experiencing pain, and they cope with it in many different ways. And we get to learn about it if we're engaging with them. And so I wanted to have a brief discussion about how we help them in the midst of them having experienced pain and using coping strategies to deal with that. Symptoms for mental health or addiction, regardless of what happened or what started first, the client's doing what they're doing to get relief. It may be from the outside that we are in a place where we don't really truly understand that, but they're doing what works for them in the moment until and if they choose to learn different strategies. So if we're sitting with people that are engaging in high-risk behaviors, instead of pathologically looking at them and condemning them and kind of getting judgy, we need to engage with them about what these behaviors do for them, so that we can kind of open the door in the conversation to help them not feel stigmatized and ashamed. Um, the labeling that we talked about earlier, we can get in the mode where we get frustrated or worried about clients, and we actually can get in this place where we're not feeling so great about the choices they're making. And it can be rooted in worry or feeling overwhelmed. But in any sense, if we're going to reach people, we have to practice in a way that helps them feel supported as they're going through their journey and still using and maybe not taking their meds. Harm reduction doesn't remove a person's coping mechanisms until others are in place. So we're honoring who they are as a person right in the moment if we're doing some harm reduction. And it's practical. There are ideas aimed at reducing negative consequences associated with drug use. It's realistic. It deals with what's going on with that person right then with their substance use disorder and health issues. And it's also social justice for any of you that are on this call that have been working in your communities, and people may feel differently about supporting folks right where they're at when they're using or they're not taking their medication. And so we have a job to advocate about what this really means for them, because harm reduction can be the first step to long-term abstinence if the client wants to work on it. And supporting folks that are making harmful choices can be morally ambiguous for us. And that's why I encourage us talking about it, because sometimes people are going to be really overwhelmed with the choices people are making. Some of our folks make choices that really affect their health and can also affect them not being around or being much sicker. If we support clients and don't engage in fixing behavior, which we talked about before, we have a chance of helping them long-term figure out what works for them and improve the outcomes of what's going on with them, and hopefully retain them in treatment, and not lose clients. I mean, sometimes we have clients that pass away due to their high-risk behavior, but if we're supporting them with provide emotional relief and acknowledge that we're not solely responsible for them, we've got a chance to really impact them in a positive way and let them be who they are and talk to us about it. Some of the common harm reduction interventions are listed here. You may all be doing this. So safer supplies, anything to check for drugs that may have high risk of overdose, naloxone education and distributing, reducing use or controlling use, helping people kind of figure that out, and encouraging people, if they're interested in medications for alcohol or opiate use disorders, showing them where those are, making sure they get linked, and then low threshold for services, which means no matter what you present with, if you're intoxicated, you have mental health issues, we're going to try to meet you at that, at your level and provide some type of intervention or service. We're not going to kick you out of treatment. We're going to try to provide you service. And that doesn't mean we have to put someone in a car that's extremely intoxicated and not able to discuss things with us. It means we're going to look at that person and say, okay, maybe we had plans today. What is the best service, the best thing we can do for this person to keep them connected with us and feel supported? And there's a number of things we could do, but what we're talking about is no matter how they present, we're going to try to meet their needs. Why harm reduction is important is because relapse, not abstinence, is the most common outcome following treatment. Numerous studies find at least 2/3 relapse within 90 days of completing treatment, and overall rates of abstinence for treatment are not correlated with any type of modality, inpatient or outpatient, is about 30%. And so the longer we can keep people engaged with us, the better chance we have of helping them figure out about those types of things, figuring out relapse when it happens, deciding if this lifestyle works for them, all those types of things in the moment, we have a chance to continue to help them with, because the chances are, even if they went to treatment, they may relapse, and we have to help them pick apart how that happened and if they want to do something different. Harm reduction principles. are many of the things we're talking about now. I know I need to wrap up, so I'm not going to read this, but you have it in your slide deck. It is all part of recovery-oriented care, which is health and dignity, uh, keeping in mind that people have socio and cultural factors that affect their ability to engage in treatment and what they are doing with regard to how they're coping. And it's individual and pragmatic, and it provides autonomy, a participant empowerment to make decisions, and it looks at tiny changes. I know I said I wasn't going to read this, but I want to talk about the last one. And it also really honors a person making decisions for themselves without us terminating them from care, even if they're high risk and dangerous. The last part I want to do, which should take me about 5 minutes because I don't want to, I'm already running late. But it's important. If you're going to practice harm reduction as a team, the things that you need to understand as you engage with clients have to do with understanding the risk, set, and setting. Nobody is out and about in the world in a vacuum. We need to understand what's going on with clients so we can provide them the best harm reduction in the context that they're dealing with things. Understanding risk set and setting can give us, give all of us on a team more tools to support harm reduction for participants. If we know exactly what someone's dealing with, we have a better chance of talking them through what will be workable for them. And so risk is the risk itself related to drug use or sex work that you're discussing. And so obviously patients have to be at the place and the mindset that they want to talk about this with us. But these are the things we're looking for as we're working with them. And set is mindset that someone brings to the situation, including thoughts, moods, expectations. So what are they thinking, feeling? What do they think is going to happen? And then their setting is the physical and social environment where the person is and their perception of how they can promote and reduce risk. These are the things we need to understand from the clients as we work with them and engage with them, because there's all kinds of different coping strategies we can apply and harm reduction strategies to help them in any one of these situations that are important. So I know some of the topic with clients that have co-occurring disorders on teams is what's the risk? And so one of the things I wanted to provide as we wrap up is talking as a team about what issue, what risk is being presented, and then what kind of source of harm might be connected to this main issue. Is it high, medium, low? What are the substance use? What's the risk for overdose? Understanding those things for us as a team helps us then provide services to someone in interventions that are stage-based for readiness, but also, helping them be more safe as they're going out in the community. And harm reduction, if you're using it, lessens infectious disease and transmission through education and resources, connect and distribute like overdose medication, education and counseling, referrals to treatment if people are connected, and overdose reversal medications. What we're hoping for is to reduce overall deaths and promote linkage and facilitate integration. So they're getting comprehensive services through us and also our partners if we can't provide all the service. And then hopefully what we're doing is reducing the stigma and promoting a philosophy that people can get better and there's hope through peers and other examples of recovery support services. People can feel like, hey, I can do this. I'm going to stop because I know we're after time. I don't think I need to sell it more why harm reduction works, but the biggest piece at the bottom is we want to try to keep individuals engaged in care if they re-engage risk at any stage. So what we're trying to do is really provide space for people to be open about who they are, what they're using, what kind of things that they may be doing so that they don't feel isolated. and value the people that we're with, that they know what would be helpful and what they need, so that we can support them in that. And it is rooted in evidence-based practices that have shown marked decreases in health and social harms. So it's important to be doing. And some of the models are listed here that you can use, think about. And then just a last thought about safety. Just sobriety does not necessarily guarantee that people are going to be appropriate in their conduct. And intoxication doesn't mean people are going to be inappropriate as well. We need to be assessing immediate safety concerns that we might need to intervene in. And then how can we still be helpful for that individual who presents in our office having recently used substances? In any case, you're always going to follow your agency policy and consult with your supervisor if you have concerns. I know that went over. I'm sorry, everybody, because I know you have time for discussion. Well, it was only 8 minutes.
They're used to it. Great talks. Thank you, Melissa. One question or a point maybe you're making at the end there, which I think is something that I've pondered at times, is around this idea of harm reduction strategies are not intended to be passive, and they're not intended to
Absolutely.
You are always in your back of your mind thinking, how can I help this person get to the point to accept treatment? And I think sometimes I meet teams and providers who I think lose sight of that piece of it, that in your risk assessment as part of this is that, walking by the person who has been perpetually homeless and now is smoking fentanyl and now has gone through another overdose. And it's almost like in your back pocket is always having ready, like, if you said, is today the day? Because if today's the day, I got a place for you. Like, have that place, have those things in mind. Because I think the two need to be in tandem. And sometimes I feel like we got all in on harm reduction and we lost sight of the really intentional.
Well, and I would argue, I think what happens is you get overwhelmed with the case and it doesn't feel like it's moving forward. And saying, okay, I'm overwhelmed, or I don't know what to do next because they keep doing the same thing. I've talked to teams and they'll say that. They're not trying to be mean about it, but they're like, gosh, I'm so overwhelmed with this case. They expect people to change. But then what happens is that expectation or that frustration or feeling burned out can keep us from going, wait, okay, what is that intervention I need to do with that person? I need to keep going to see them.
Yes.
I need to listen carefully, because it'll feel like you're not doing anything. Sometimes I've had teams say that, well, okay, so, they're using clean needles, they're still homeless, they engage with us, but, they don't seem to be wanting to do any of that. You have to still hang out with the person and see what's going on. You can't get so bummed out with a lack of progress in your own mind to not do an intervention or see when maybe the tides have turned. Like you said, someone says to us 100 times, I want to go to rehab. Miss Melissa, I want to go to rehab. And 100 times I may have tried to place them before this and they end up scooting out of treatment, right? But the next time they say it, I got to be present to try to do some of that and kind of flip it around, not contingent about if they'll fall through, because maybe this is the time. And not get cynical about it, because you can go there. If you sit with clients long enough, you can soak up some of that energy of them not feeling good. I'm not laughing. I'm kind of like, you got to be careful, because that's what affects your ability to engage. I don't know if that speaks to other people. But, having that soft heart for folks, even when it seems like they're not making any progress, it's okay for us to talk with them and just hang out and figure out, because they will talk to us eventually. I mean, not everybody. I mean, it's not perfect, but is that sort of what you meant?
Yeah, it is. And I think the emphasis on the hanging out with them. So it's really trying to find the foot in the door where it's not just dropping off the sandwich, the water bottle, and the checking your prescription. See, I'm
how are
going
you
to
doing with your
actually
meds? Yeah.
spend time with you
Yeah.
right now.
Yeah. Yeah. How can I do that? What's their creative way to
Mm-hmm.
get that done? What do they like? What, especially at the beginning stages when people don't think they have an issue, what are they into? I've gotten plenty of people to sit with me when they eat a honey bun and some orange juice and they get to smoke.
Yeah.
Um, driving them someplace important to them, in the car. And I'm sorry, I know Medicaid doesn't reimburse it, but car talk is phenomenal.
Mm-hmm.
Sometimes they don't have to look at you and they can kind of talk and you can ask questions and it's not so much pressure. So yeah,
Yeah.
yeah, harm reduction is to help people be safe no matter what's happening. And you can't lose sight of the fact that there are still clinical interventions that we can be doing with folks, regardless of stage or readiness. Just hanging out is something you do at the earlier stages and getting to know them. So,
Yeah.
yeah, that's important.
Thank you
Yeah.
again. This was great.
Okay.
You
I hope
hit it
so.
on the
I
money.
know it was a lot.
No, it was
Melissa,
great.
do you have,
Yeah.
could you point us to some specific resources about some of the harm reduction strategies you pointed out? Because what I liked
Yeah.
about it is it was very specific about the range of different types of harm reduction strategies. And I think for a lot of people, that's really helpful than just thinking of it as a philosophy, but rather like what are
Yeah.
the practices,
Like,
or
what can I
people can
do?
sometimes feel
Yeah.
limited by there are only certain ones that they think of, but there's a lot more that you shared that I think would be important to be able to share. And we do have a hand up,
Well,
so yeah, but go ahead. I'll let
yeah.
you answer first and then
No,
I'll
I was
get
no,
to
I
that.
was gonna I will forward you some things. I think when you're in the moment, harm reduction can be super creative too. For one client, I mean, not helping them work on assertiveness skills and boundaries around not handing their debit card to the drug dealer. There are so many things we can do for clients when we know them well. And so we can get really creative and yeah, but there's some basics that are just things that we need to do. But yeah, a lot of staff are like, they do more than they realize actually, when you start looking at the harm reduction stuff. But yeah,
Hmm.
there can be more than that. And I would
Hmm.
be happy to. I also owe you the staging guide. So I will definitely pass that on. I think it's just really helpful for
I
folks that
found,
aren't staging,
yeah.
you know.
Yeah, I
One
think
else
I
shared
found
it,
a
I
link.
think.
I found the link and shared it
Okay.
with them earlier.
Although the
Okay, cool.
version that we shared uses persuasion, not motivation. So I don't know if
Oh,
there's a newer one or if it does still say
Well, let me
use
take a look
different.
at it
Okay.
and I can also offer an explanation. I know it can be confusing to people, but
Some of the different
yeah,
names. I'm going to
yeah,
let
I know.
Monica, who's got her hand up, just talk here to see if Monica, did you have a question you wanted to raise related to this? You all have to.
I did not. I accidentally
Oh,
clicked
okay. No worries.
Well, it's nice to talk to you. Yeah,
Yes,
you're
exactly.
like, great. Okay, I don't want you to say
the pay
anything.
for this.
No problem. Great. Well, thank you, Melissa. And I,
yeah.
I just kind of a last call for any questions for Melissa before we shift into other topics. It's like we don't have anything in the chat right now or in the Q&A. You can put it in the Q&A
Yep.
or feel free to raise your hand.
No, but if
Yeah.
you have the chat open, there's a lot of thank you, appreciate this, appreciation.
I see. I saw lots of hearts and thumbs up. I actually want to hang out with all of you. Like it would be so fun, right?
Yeah, we should have like a national act conference sometime.
Right.
Just, throw one together.
Yeah, in the midst of everything else that's
Well,
going
lots
on.
of hearts on that one.
Yeah,
We're working on it. We're working on it. Have been for quite some time.
I know. We got to build a website first. We can't even do that.
It's all good. It's all
We'll get
good.
there.
It's all good.
Well, we've got a question in the chat. Oh, okay. This has to
What?
do with the licensing, so we can
Yeah.
Okay.
back channel behind that one. Other comments or questions that people want to put into the Q&A or raise your hand now's your time. You've got 143 of your best friends doing this work all over the country. So whatever you want to bring up, or it could be kind of a follow-up to something that you've posed in the National Act listserv. I know there were a number of questions that were posed on there in the past in the past couple of weeks, actually, there were a few. Anything that folks want to add to that? Quiet
This
group.
is unusually quiet for you all.
Oh, question about, and let's make sure too, I'll answer this question in the chat, but if you could put it in the Q&A box too, just if you want to answer their question. Are there any co-occurring specialist chat sites?
Ah,
Do you guys have anything for the center? For your center?
Um, so we're working on stuff too, from podcasting to, no, we haven't set up a chat. What we do have is the Substance Use Disorder Center for Excellence. Lots of information, lots of stuff going on. There's not a chat, but there is a way to sign up for, I believe, our updates. You can go on our website, and it's there, and you can get little like, hey, thinking about this, like, so it's a little, hey, these are the trainings. We're doing trainings in Ohio specifically, for that, but I believe you can sign up for, the notification, and you get
It
little snippets about like harm reduction or other things.
You can, Sandra, also at least pose that to the National Act listserv, specifically for co-occurring disorder specialists and kind of, channeling your question to them more specifically. Because often there will be something specific to nursing, and then all the nurses in the group, will kind of chime in and answer the question. So that's kind of broader than what you're describing, but is also, I think, a place where you may find folks kind of doing the same thing. And again, very specific to ACT in that role. But if anybody else knows of any, I know some states have some set up where they've just got all of their co-occurring disorder specialists within their state, kind of looped into a listserv. But I realize I'm not helping you if you're asking about it, and probably don't have that available to you. But those are at least two options that I'm aware of. Yeah, Lorna, you're gonna say something?
I see somebody's asking about how do you sign up for the listserv. So I'm going to drop that
Great.
in the chat. It's a little survey you fill out, and then we move you over into the listserv.
Okay, there's also a question about how would I go about getting an IDDT training? Just email the website sent from above. So we sent the website for the Center for Evidence-Based Practices at Case
Mhm.
Western.
Yeah.
Is that the best way?
Um, yes, that would be the best way. And
Okay.
then our process is, you can ask us a question, and we have one of our consultants actually manages that. So one of us will reach out to you. His name's Scott. And he may reach out to you directly and then talk to you a little bit about it. And then usually we get, um, one of us will get back to you and kind of talk a little bit about it more.
Okay, I put that in the chat too.
I put in the chat, um, someone was asking for resources, so I put the link to the library. I think I can put, yeah, there we go, to go to everybody. The link to the co-occurring library, we have some stuff in there, that you can click on and look at. Our stuff's free, so have at it.
Just going through the list. Okay, there's a new question. I think there's a distinction between clients that are not ready for change and those that see the program to meet their needs. So, for example, food, housing, money, benefits.
Yeah.
And so you're, kind of banging your head against the wall. How do you know the difference and or pull the plug, so to speak? a tough
Well,
one.
I think it's exceptionally resilient that someone would come to the ACT team and then engage with us so they get their needs met. So I don't know, engagement's engagement. I would take it and run with it, and help them. If they end up choosing to not work with us or choosing not to open the door, if they're housed, if they have food, if they got their benefits restarted, that's recovery for them. That's them not in the street. That's, and if we can do that, that's important. Um, yeah. And
Mhm.
not seeing it as anything but resilient, actually. I
Yeah,
know it doesn't feel resilient. I know it doesn't. It's like, okay, I'm running
right.
around, and then you don't even want to meet with me to talk about anything. I know it
It
doesn't feel that
reminds
way.
me, it reminds me, Melissa, of like something we often say is that somebody who agrees to enroll in ACT did not agree to accept everything that ACT has to offer. So ACT is
Right.
offering a lot of things. So if they're accepting your assistance around keeping housing and getting
Mm.
groceries, and sometimes I
Yeah.
staff they're like, I feel like they're using us like a taxi cab. And I'm like, if you
Mhm.
really believe they need this level of care, then you're going to kind of be a little bit of a taxi cab because at some point that
Yeah.
conversation is going to happen where they're going to raise something with you that
Right.
you can go further.
Oh, well, and they're going to feel more comfortable that you kind of listened to what they needed in the moment and didn't kind of, yeah. Yeah, I'll take whatever. But sometimes it feels busy on our end and not like one-sided. Let me put it that way. That doesn't
Yeah.
mean that's actually what the client needs is us to be busy for them, actually. Melissa, where did you share the link to info?
I just pasted.
Okay.
So some people were saying, it's tricky because there isn't like an email per se, but there's the
Yeah.
contact us, and then they would send a message that way. Is that the best
Hmm.
way to do it? Okay.
Yeah.
And
Yeah.
somebody will get back to them
Yeah.
about that. Okay,
Absolutely.
great.
Absolutely.
So they can say, wanting to get IDDT
Interested in the
training.
IDT,
Yeah,
and then one of us will call and talk to them a little bit more about it.
exactly. Okay, great.
Yeah.
So I think everybody's got that.
Oh, I
And
love that comment. Moving at the speed of trust.
I do
I
love
like
that
that.
too.
Yeah.
Oh, that's wonderful.
And Stacy Smith saying they're only doing what the system has taught them to do. If you can't get those needs met elsewhere, you can go to where you can. You go to where you can. Yep.
Yeah, you do what serves your interest in the moment. We're creatures of going towards what works, even if it doesn't look like it works out from the outside from us. Um, you know, we all have weird coping strategies, maybe not ACT level need, but we all have coping strategies that maybe aren't the best. Um, you know, lots of good questions and comments. Thank you all.
Any other? Oh, yeah, there's another one here. Okay, yeah, contact. Yes, they will contact you, Muriel. Well, you'll need to I think you'll have to fill it out.
Uh, oh,
Oh,
I think what's being asked is about when their fidelity review would happen, and that's this. Their state leadership decides the order.
oh, okay, got
That's
it.
not
Okay, this
us.
is separate. Okay, okay. Got it. All right.
Starting to have flashbacks. Fidelity review. I didn't see that one. Okay.
I know it's hard to know which questions people are asking about. Um, well, thoughts on, and it could be that your folks answer might be guided by even the topic of t from today, but just thinking about future training and areas that we want to focus on in here. We've got the survey that you all filled out, which we, as Lorna said earlier, keep circling back to. That's how we kind of, specified this particular topic. Also, the last one that we specified around outreach and engagement. Other topics that you want to see us bring into this group for future didactic starting in August. Feel free to just throw that into the chat today. So anything that you think would be helpful to help guide your work, anything that's like particularly relevant to the times. I know we're in, as I said earlier, kind of a challenging time around funding, that kind of thing. Anything? Pretty quiet group today. Okay, racial trauma healing. Other topics, keep them flowing. This is a quick brainstorm. Okay, motivational interviewing. Thank you, Jacob. Other topics? Keep them coming. Okay, so the collaboration with the QMHP in the agency.
So, Mo, you're a peer supervisor. So maybe you're thinking of it from that perspective.
Looks like it maybe, and peer.
Yeah. Okay.
Collaboration between peers and the mental health professional on the team. Is that what the topic would be? Okay. Self-care. Okay. What about any particular interventions? Any specific, again, we don't have a lot of time, so it's very mini, but it's kind of more just like bringing everyone up to speed on a particular set of techniques or interventions or services. Anything in particular? Just a yes, please. I love that. A sort of engagement. Okay. And we can also point you to the previous one that Lorna and Christine Powers did on that particular topic too, that's on our website. Listen to hear and not respond. Okay.
Mhm.
CBTP, CTR. Okay. Some of the topics we've had in the past. We could kind of drill down a little bit more. These are good specifics. Documentation as it relates to ACT. Yeah. Ways to implement ACT without having an in-house psychiatrist and still meeting fidelity for funding purposes. Yes. Okay. That's a tough one. Yeah. Okay. Thank you. Documentation. Okay. Great. Some good thoughts there. Moral injury and coping. And completion and use of the timeline, do you mean the timeline for substance abuse? Be good to just clarify that one, Charlene, if you can. Appropriate referrals, how to determine if someone is appropriate for ACT, exclusionary criteria and why, increasing caseloads, onboarding process of new clients, great. Okay, ways to meet fidelity without. So that's interesting. That's the second one that has to do with meeting fidelity without certain staff members, which I feel like is also kind of like how do you, at least in the meantime, get needs met in the team? So this is great.
Yeah.
Referral criteria. Okay, good. This is great, you guys. Good list to get us thinking about our next couple of topics. Okay, and it's the psychiatric history and events timeline. Okay. Well, and just what what kind of tools people are using for these kinds of things too, because I think that's a particular one that I know at least the PACT manual advocates for, and not all teams are using that. So it'd be good to know kind of what people are using. Okay, this is great. Well, thank you all. I know it's at the stroke of 4:31 on the East Coast, a little earlier here on the West Coast, but we'll let you all go. And thanks for joining us for yet another month of National ACT. Melissa, thank you for joining us. It was fun
Yes. Thank
to,
you again.
yeah, meet you
No problem.
and learn more from you. And we'll get those materials then once you get the updated
Okay,
staging
sounds good.
document. That would be awesome. Okay, thanks everyone. Thanks for the hearts. It's nice to end a meeting with hearts. All right. Bye.
Bye.